Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and today we're going to talk about when you do removable versus when you do fixed functional appliances in phase one interceptive. This could also be in comprehensive as well. But I'm taking a really great course right now. You should definitely look into it. It's by Dr. Simon Wong. It's a really early airway focused phase one program, and I know most of the stuff already, but it's always great to see how other people do it. I'm doing the on-demand program. He is going to have a live program in New York or in the New York area in the end of September, and I'm planning to be there at the moment. So I'm going to park it on my website once the dates are set, and I might even be speaking a little bit. I'm kind of psyched. So yeah, you should definitely check it out. And you guys, I'm not compensated for anything I say about them. It's just that I really like what he has to say. And if you're looking for an actual organized course, which really is not my thing, I just throw a bunch of YouTube videos up and I help people one-on-one. So I'm going to be partnering with him. So since our philosophies are really similar. So I feel really comfortable sending you guys to his course and not having your minds messed up. So when you come back to me for one-on-one help, it's pretty seamless. But anyways, so I learned a little bit in his course, so hopefully I can explain this a little bit more. He likes to use the analogy, and granted, this is his analogy, not mine, but about being in the quicksand. So you need to lay your foundation. There's timing for when you do appliances. Specifically, he's usually talking more about expansion or sagittal appliances. He says don't do it in the quicksand. So he likes to wait, which I've always said. I always say never start appliances until your sixes are erupted. This is the foundation. These are your anchor points. I've been saying that forever. You guys know that. A lot of you guys are. He will do it, is what he says, but he says it can get messy. And also there's the whole psychosocial, there's just usually no reason, there's usually no reason. And I'm totally fine with, your habit correctors or your U trainers and your MRCs, fine if you want to use that. Don't bill phase one for that, but I'm totally fine doing that in the early, especially if the patient just maybe needs a little relief, needs to work on nasal breathing, maybe we'll get a little arch expansion, that's cool, nothing wrong, no risk there, right? But as far as the full-time appliances, I like to wait until first molars are in and they have at least maybe 6 anterior teeth in, at least, if not all 8. That's my timing. And usually the timing works well psychosocially, maturity-wise. Usually they're able to handle it by that point. Boys usually need to be a little bit later, but usually we're not as critical in boys as girls because we don't have such early puberty. So it all usually works out. But he also likes to give the analogy of, again, you don't want to be in quicksand. So there's a point, where the timing isn't great for removable because you're going to be in quicksand. You're going to be losing teeth like crazy. So for example, he and I are a little different there. I have no problem using fixed. And matter of fact, I like fixed better. Just because, especially in the more later mixed dentition, because you're going to be in the quicksand. Teeth are going to be coming in and out. There's a period where you start, losing teeth and teeth start coming in real soon. So look at this 4 here, and this 4 already came in, So this patient is going to be losing teeth like crazy over the next 6 to 9 months, which is basically the duration that these appliances are going to be in. So if you do removable, you're going to be constantly remaking it, and having fit issues. And every time there's a fit issue and you have to remake it, then you're going to have to make a retainer. Your lab fee bill is going to be ridiculous, because the clasps are going to have to be changed as things come in and out. It just doesn't make sense to me. So in this case, I'd be using fixed. This is just me. It's different than Dr. Wong's philosophy, but that's just me. I have been using more 3D printed, metal 3D printing, and there's a fair amount of labs that do it, especially in the US. There's a handful in Canada. I'm not sure in Australia. You guys are my top 3 followers, but you can look. Just Google 3D printed expander lab in whatever country you're using. Tons of them in the US. I'm not even going to mention them all. Not all the ortho labs are doing it, but many are. It's going to be a little bit more expensive, not ridiculously more expensive, maybe 50 to 70% more, but you don't have to worry about when you get to this situation, maybe not as bad here when the 7s come in, but when they start coming up, the gums come up with it and it's just too pinchy in the back. So you end up having to cut the band down, or you could damage the gum and then you lose retention. The 3D printed is like an onlay. It's custom made. It just lays over the top and there's no spacers, or you save an appointment. And saving an appointment to me is worth $50, $70. And not to mention the discomfort and the chance of infection and stuff like that. So I love a 3D printed expander, and just, little thin resin on the top, just paint it on lightly, and no problem. Easy, right? dual cure resin, self-cure resin, whatever. Now, in a case like this, where we're not losing any back teeth anytime soon, I mean, we are at least 6 months from losing any of these, as you can see, then I'm fine with removable. Great, have some good clasps. Make sure it's nice and tight. It should just drop right in. You shouldn't have any problems. As long as they're actually wearing it as directed 22 hours a day, it should continue to fit. You shouldn't have any problems. Just keep in mind if they dilly-dally or treatment gets delayed, you might get into this situation. So make sure they realize that this treatment plan is for the next 6 months. If something happens, they lose, they break, they dilly-dally, they delay, they don't get things done on the right timeline. And if you start losing teeth, then they're going to have to purchase an additional appliance. I would just make sure you put that in writing, because I have too many doctors that maybe they don't manage their patients as well, and they ghost them, and then they get into this and they're like, well, wait, we didn't know we're going to need a fixed expander. Who's paying for that? Well, your patient should be. But if you didn't explain how this is going to work, that they have additional fees if they dilly-dally, then they had no reason not to dilly-dally, right? So all right, anyway, so regardless, it should work out great. And just remember, fixed has to be worn all the time. So if they're intermittently wearing it and they're not wearing it to school, you're not going to get the right type of turns. So, and it's not going to retain, it's going to fall apart. So you have to pick your patient wisely. And I would also mention compliance-wise, if they're not, then if they have to upgrade to fixed, there's going to be an additional fee. All right, thanks so much.